Good afternoon. Welcome, everyone. Thank you for attending the second day of our 2026 Spring Graduate Colloquium, where Aspen and USU doctoral students have the opportunity to showcase their hard work in research and projects. We are excited to again take part in a meaningful discussion and help inspire and support the next generation of scholars. This session presents a project completed by Dr. Nancy Sanchez, focusing on impacting patient identification barcode scanning in ambulatory care. So please help me welcome Dr. Sanchez.
Hi, everybody. Good afternoon. Thank you for joining today's session. I'm really excited to be here, and I want to thank the team for inviting me to present today. So I'm going to talk a little bit today about my project that I completed, impacting patient identification, barcode scanning in the ambulatory care, and why was it important to me and for our patients. So a little bit about myself. I am a Jersey girl native and a California transplant, so I do have a tendency to speak a little fast, so I do apologize for that. I'm a proud mom of a 21-year-old daughter who's going into education, and my 12-year-old toy Maltese, who's my pride and joy. I have been in nursing 37 years with over 20 years or so experience in maternal child health, encompassing education and ambulatory clinical practice. I am passionate about quality and safety. It's my love and my passion, maternal mental health, and employee engagement and retention. I'm an advocate for domestic violence awareness. I have in collaboration with other leaders. I have presented at LEAP TA Healthcare Conference to help support employee engagement and retention, along with having a poster presentation as we speak at the AAACN National Conference. My interests and hobbies include being the best mom that I can be and the best nurse that I can be. I'm into sports, lots of sports, Yankees, my number one team, New York Giants, etc. Running, I love to run. Reality TV, I hate to admit that, but I do love reality TV, wine tasting, cooking. So I'm really excited about that. And I'm excited to be here today. So the background of my research, why did I decide to do this? In doing my research, ambulatory care is becoming increasingly more complex. And, medication administration safety in the ambulatory clinics that's what we do in ambulatory. We give a lot of medications for our patients, and patient barcode scanning is not the norm in ambulatory care setting. And me transitioning from inpatient as the maternal child health director to ambulatory as the director of education, I started to see this, and I started to see, some fallouts and some potential near misses. And healthcare organizations, as I mentioned, do not routinely look at barcode scanning in ambulatory. So what can we do? What can we do to help support our members and our patients? Um, some of my research included, doing a deep dive, and it's not a lot of literature out there to support ambulatory care and barcode scanning. Nationally in 2020, 7,000 deaths were contributed to medication errors in healthcare. And 30% of the errors occurred during medication administration. Nearly 100 medication errors go unreported that can harm patients, and 27% of the patients experience medication adverse events in ambulatory out of the 7,000. So that was really eye-opening for me to see that. So with my research, and of course, the overall goal of this project was to ensure that we have a process in place to improve quality and safety for our members. It's important that in ambulatory care, along with inpatient, we have a lot of regulatory bodies and agencies that help support our practices in the inpatient care. But ambulatory is a little bit different. We have state agencies such as DHCS that provide oversight for primary care in our pediatric departments, but we don't have what we say in a joint commission. Our joint commission is Department of Health Care Services, and we want to ensure safe care is provided to our patients. So when I started to do this project, I wanted to do it. It took a lot of research and time to find the research that helps supports barcode scanning and utilizing wristbands in ambulatory care. Because as we know, in the inpatient side, we're scanning our bracelets and we're ensuring that during a medication administration process, we are barcode scanning prior to administration. And in my organization that I work at, and this is not a normal process in ambulatory. We don't normally typically place armbands on our patients when they come to us, and administering the clinic administered medications. So I decided to look at the data in the clinics in the service area that I was working. And I noticed that one of our clinics, we were challenged with seeing a rise in medication errors or near misses. And I decided to take the research that I was able to compile and decided to take a leap and apply armbands on our patients during this time period. And it really showed, as I go through my project, it really showed an improvement, but I'll talk about that as we continue. As we know, evidence in barcode scanning, there's a direct correlation that it does help to ensure safe practices and delivery of our medications. What I did during this project was I targeted, of course, any patient over the age of 18, utilizing technology. And as we know, technology is our goal, utilizing the technology that we have in place to help ensure safe practices for our patients and ensure appropriate patient identification of our patients. So, this ended up in my PICO question. Among adult ambulatory care patients, will the translation of Khammarnia, that's the research article that I used and their research on patient wristband barcode scanning compared to current practice? And the current practice right now in the ambulatory care setting that I use, we did not use patient identification bands during medication administration. Will this impact medication errors over the 8-week period that I implemented this process? So let's go on. Of course, utilizing the theoretical framework, I did utilize Gene Watson and, of course, Kurt Lewin's change model, which helped provided the scientific underpinnings for this project. And, of course, focusing on Watson's Caritas processes helped guided the provision of compassionate care with the focus of safety and inclusion. And it's all about active verification for our members. And we want to make sure when they come into the organization, whether it's inpatient or even in the ambulatory care setting, that the patient is actively engaged in the process, ensuring that they're doing, when the nurses are doing the double check or the clinical staff are doing the double check, that the patient is also confirming as well. It helped to utilize in this process, helped to encourage healthcare teams to reflect on the 7 rights of medication administration. Well, now we know that we use the 10 rights of a medication administration to help ensure safe practices. The 3 main principles that I did focus on during this quality improvement project was to be present, being present during medication administration. We all get distracted, we do, but it's really important to remind our teams during this process, take that pause, and reminding our staff and providers to become really attentive and mindful during the medication administration, and to include the barcode scanning for patient safety. It really talks about the spiritual practices of, why are we here? Why are we in healthcare? To provide safe care to our members, quality and safe care to our members. And then it allows for miracles. And we know that, change can be tough. We all know that. We have become creatures of habit, but it's, and we do know that healthcare is changing very rapidly. So it's really important to give that team the time and recognize the team for that positive change and ensuring that, they know this is the whys of why we're doing it and giving them that information. It's really important. So I utilized Gene Watson's theory as I continued along with the process. Applying Kurt Lewin's change model. Love Kurt Lewin's change model. It really does help to take a step-by-step approach, especially when you have a staff or a staff or employees that are really resistant to change or really have a hard time with any type of change. And using this change model really was a three-stage model, as we know, and it refers to the unfreezing, the change, and the refreezing. And those are the steps that I used in collaboration. And this was all done in partnership with my leaders of the site and, of course, with the staff. And it all started with the whys. Why was this important? So the first thing that I did when I approached the team to make this change or implement this project was giving them the why, showing them the data, bringing the team in to help them understand the need for the change. And because everybody wants to do well and they want to understand the whys, and giving them this information to see where they are in the process and why, what happened or what is happening that may cause an adverse event for our members. And it's just to bring that awareness to our teams. Again, sharing the whys with any type of project or implementing any type of a project is so important and so critical to get the buy-in from the teams. So then the next step was the change. It was bringing the evidence-based practices to the team and showing them the literature and the evidence-based to support the process and to support the need to bring this change in. And allowing them to know that, using the patient wristbands and active verification was really, really important during medication administration process. And then, of course, making that change, bringing it in, rounding all the time. I was there at the site at least 3 or 4 times a week, just to check in, iron out any kinks that they were having with barcode scanning, and ensuring that process was going smoothly, because we do know that we don't want to interrupt their current workflows or their operational workflows, because the change will impact access for our members in the ambulatory care setting. So it was really important to stay on top of it and stay engaged with the staff, the clinical lead, and our providers and our physicians to ensure that they were still on board with this change, and ensure that there was no bumps in the road, and really try to eliminate those bumps. And that's our role as we implement any type of a project. So it was really great to see the team, really great to see their engagement, and providing week by week data to them to show whether they were making progress, whether this was impacting, and seeing any changes, and getting feedback from our members as well. And during the refreezing process, it was great to really reinforce and celebrate the wins, as I mentioned, to give them their progress as how they were doing, and really engage and getting their feedback, and really hearing what they have to say. I was very fortunate with this department that they were so engaged and so happy and so on board to taking this project on and seeing what it could do. And they were really, really excited. I was really proud of this team, and it really helped to enforce sustainment with our members. And even though, and I'll go in with my summary, and I'll talk about the summary at the end. But even though it's a very large organization, it was a very small department, small test of change. It was, my goal was to eventually spread the implementation of the bands. But again, with technology, it's hard to implement printers, etc. But I'll talk about that later on as I come to a close with the presentation. So going back to the literature review, looking at evidence-based practices, it really does highlight the effectiveness of barcode scanning for accurate patient identification during medication administration. It really helped to understand how patients' wristband barcode scanning helped to improve quality and patient safety in ambulatory care settings. And as we know, a lot of our data and our research really focuses on the inpatient setting, but now there's a nice shift with focusing on ambulatory care settings and quality and safety. So I do anticipate, as we continue to make this shift and focusing on safety in the ambulatory, that we're going to start seeing more research and more evidence-based practices to help support improvement. One area and opportunity for improvement is patient falls in the ambulatory care setting, because we're starting to see that as well. So utilizing the integrated review and the problem statement, it was great to bring this all information together and implement a wonderful project to the ambulatory care setting. Of course, an integrated approach was used. Thorough research and a literature review to help support the problem statement. Again, there was not a lot of research on ambulatory care setting, but I was able to pull it. And I do anticipate we're going to start seeing a lot more of this data and evidence-based practices to help support quality and safety in ambulatory. Of course, utilizing multiple databases, as we're all familiar with, ProQuest, Google Scholar, EBSCOhost and all, the Cochrane Library, and the PubMed. And then, of course, filtering it down to see what was best appropriate for this time period was crucial as well. So there were significant themes during the review. The literature showed occurrences of medication administration errors in the ambulatory care setting, with the recommendations of using BCMA technology to improve patient safety during medication administration. As we know, there was some research and literature out there that talked about the impact of workarounds, how important it is not to create workarounds. And as we know in healthcare, we truly encourage not to support workarounds. But the key with the workarounds is what's happening. It's so important for us as leaders to understand what is happening. Why was a workaround created? What may work today as far as a workflow may not work tomorrow. And it's so important to really stay on top and connect with our teams and get their feedback to understand, what is happening that workarounds have been created. The studies also consistently identified the importance of developing practices to administer medications to help improve safe practices in ambulatory care. It's really so important in the clinic setting when we're administering clinic administered medications to ensure that we're grabbing the right medications. And, we don't have a Pyxis system. Most ambulatory care settings do not have a Pyxis system or an automatic medication dispenser system in ambulatory care, so that we can do that double check. So it's so important that we have a process in place in ambulatory to ensure that we're administering the medications correctly. And then, of course, back to the workarounds. We want to make sure that we do not have workarounds to support that during our medication administration process. So the project design was a quality improvement project, and it was aimed at enhancing medication administration on safety and efficiency. Of course, evidence-based workflows were applied to help improve quality and safety in medication administration. And using innovation, we have so much technology out there to help support safe practices. So it's so important to ensure that we use them and we implement them and apply them. And we want to ensure that during the medication administration process, we are using the closed loop medication administration system. From the time of the order, from the time of verifying the order, from the time of retrieving the medication, from the time of pulling the medication administration, et cetera, et cetera. We want to make sure that we have a closed loop system, which to ensure safe practices. During this time, a retrospective data analysis was conducted using a quantitative approach. The data used was the electronic health record as well. All the information was blinded, most definitely. And what I did was during this process of pulling that data from electronic health record, I was just looking at the scanning rates of medication administration, and then tying it to our UOR system and seeing what the correlation was with that. So I didn't look at any type of patient demographics. I didn't look at that. I wanted to see the quantity, how often BCMA, how often barcode scanning was done, when the medications were administered, and then was there a UOR, or what is our UOR medication administration error rate or near misses. So I did do a pre and post implementation, and I'll go over the data. with you guys, with the team, and then use that to show whether we were being effective with applying wristbands during medication administration, or was this something that we still had to work on and hardwire a little bit further. So the metrics included, as I mentioned, the amount of medications administered, patient identification barcode scanning rates, medication administration errors, and then of course documentation errors. Using the my PICO question of Khammarnia et al. And applying it with regards to the wristbands and barcode scanning, I was able to help analyze the overall impact of medication errors over the 8-week period in this small ambulatory care setting. Small but mighty. They see a lot of patients in this ambulatory care setting. And again, it was only for our members that were 18 years and above. It really focused on using our enhanced workflows and of course safety and quality of care. And it was used to implement evidence-based practices. And it really did demonstrate the importance of applying a systematic problem-solving approach and using the reliable data analysis to help apply for broader applications. And my original goal or intent was to help spread throughout the service area that I was working in at the time. So the quality improvement, as I mentioned, it took the translation of Khammarnia et al.'s research on patient identification and applying it into ambulatory care practice. The validity and reliability of the project relied on BCMA reports and Clarity reports, taking it from our Health Connect system, which are known for their accuracy in monitoring for patient compliance. We have a very robust system at the organization that I work in. So it's really easy for me to gather this data and working with our IT team to tweak the reports that I wanted to see to help de-identify patients. So that was really, really important. Staff education, important. I'm an educator, and it's so important during to give them the whys as to why this is happening. What is happening? What do we need to do? And show them the evidence. And it's important to show them the evidence that has been out there and that's reliable and has been tested already. So re-education on barcode scanning, the workflows. So you want to do the education you want to do it during the 8-week implementation. And of course, because of sustainability, you want to do the re-education again at the end of the project. So that was important. Some of the limitations that we saw that we worked through was that if the employees did a double scan, it kicked them out of the system. So that education needed to happen throughout the whole 8-week process, because if it kicked them out of the system, it wasn't being captured as the patient's wristbands were being scanned. So it's really important to really remind our teams, do not double scan. One click and you're in. It's gonna capture the scanning. And it was really incredible to see that the staff brought this to my attention. So they were so fully engaged and committed 100% of the way. So I was really happy that they were able to escalate this appropriately. And then, of course, using our UOR event reporting system was really important to help correlate to see if using patient identification bands and barcode scanning our patient identification bands did impact our medication error rates. So again, this project really aimed at using the evidence that was out there already in the literature review. And we wanted, and the goal, of course, was to help enhance medication administration safety and efficiency. It was used to, of course, to improve patient safety and quality in medication administration. And of course, again, going back to ensuring that the closed loop medication process was complete. You want to be able to ensure that the team is closing the loop during medication administration in the ambulatory care setting. Of course, a retrospective analysis was conducted during this time using the quantitative approach and using our electronic health records. It was there. All I had to do was click a button, work with my AT team, and I was able to produce the reports that I needed to ensure progress and see how we were doing with our barcode scanning. And then metrics included the total amount of medications, as I mentioned, and ensuring that the quantitative approach for data collection was used. Of course, with any project that we're implementing, we want to ensure that we are following the ethical considerations. You know, we want to make sure it's so crucial during any type of quality improvement project. With regards to respect, you know, it's all about patients and employees' confidentiality, ensuring that privacy was maintained during the project. Again, all of the information was de-identified during the project. And we want to make sure that the patients were okay with applying the patient's identification band. So
They look
as
like
the
they need to be clean. I
patient,
don't think you can even see.
as the patients were registering for the clinic, they were asked, "Are we permitted to place your bracelet on you in case we are going to administer any type of medication or if there's a procedure to be done?" So we did get their consent. Patients who chose not to wear a patient identification band did not have anything withheld, of course not. So that's important to disclose here. So, but to be honest with you, we didn't have any patients that refused a patient identification band. Not one patient refused this. So I was very happy to hear that from our team. We want to make sure that we go through the process, ensure that we're getting organizational IRB and your university's IRB's approval. So that's important as well. And then, of course, using the Belmont principles to uphold these principles as we continue to implement any type of project. We want to make sure it's equitable and it's done with integrity. So here we go. This is the exciting part. A total of 676 patients participated in this quality improvement project. Descriptive statistics shows specifically frequency and percentage were used to analyze demographic data for race and gender. In the comparison group, the most common race was white, with 81 participating, so 43.5%. And in the implementation group, we saw 31.3%, the total of 200 patients. It was really important to understand the demographics of our patients. So again, this was pooled. I did not look at this during that time. This was just done. The descriptive data was used when I analyzed the overall data. But as I looked through the process of how we were tracking and trending, the only thing that I really looked at, the only data that I looked at was the barcode administration scanning rates and medication administration, and if we had any UOR events that were associated during that time, because that was really important. We want to make sure that, again, that we want to include and highlight any type of disparities later on if I want to continue to work through this project to see where we need to focus on. As you can see here, maybe during the Latino Hispanic population, you know, maybe there's a language barrier or a language gap. So those are the things that I want to look at later to see if there's anything other that I want to focus on as we if I decided that I wanted to move forward and continue to spread this project. Again, the project, total of 676 participants. And with that, 43.1% of our members or participants were females. And then again, 29% were male. So it's a little bit smaller number as we see more female participating in the group and going in for care. The project also highlighted the importance of scanning wristbands during medication administration, especially for our elderly population. And we saw anywhere from 18 to 95 years of age. And the most common age group was between 58 and 68%. So the results of the impact of Khammarnia's research on patient wristband barcode scanning on medication errors. I used the Pearson chi-square test to show the significant reduction in error rates from 18% to the comparison group of 9.1. So we actually cut it in half. So I was really happy. So this was a 49.4% relative reduction for both statistical and clinical significance, which I was really surprised to be able to achieve both in such a short time. During the implementation, barcode scanning usage increased dramatically from 42.6% to 91.5%. And it goes back to the staff really being engaged. It's starting from the beginning, getting them engaged, getting them to understand the need and what is happening and what is trending in their departments, and the evidence to support to ensure quality and patient safety. And it was really important to engage all of the members. Our providers were so engaged. Our IT department was really engaged. And of course, our service reps were extremely engaged. And it showed, the findings really does highlight the importance and significance of medication safe practices in the ambulatory care setting. Again, it's so important to ensure, because most of our patients do receive about 85% of their care in the ambulatory clinics. Only 10 to 15% of patients actually require inpatient care or hospital care. So it's so important. This is where they're coming. This is where they're going to get their care. And they trust healthcare. They trust us to ensure that we're providing quality and safe care to our members. So again, the literature review did provide the background to help support barcode scanning for medication and patient identification in the ambulatory care settings. Again, ensuring that the closed loop medication administration process was complete. And again, that's really important. Overall, it did help to reduce medication administration errors in ambulatory care. It emphasized the importance of using evidence-based research to educate our clinical teams, decrease unsafe practices, and such as workarounds, and then of course preventing medication errors. As mentioned, the results showed that integrating barcode scanning of the patient's wristbands and integration of the electronic health record, we have the tools, we have evidence-based technology to help support practices and ensure quality and safety. So it's so important to integrate them together and use them. And this aligned with the literature. And it highlighted the importance of technology. It's so important. We have it there. Let's use it. Let's bring it into our clinics and our ambulatory care setting. And again, it showed a huge reduction, a nice reduction in medication error rates during the implementation phase, the implementation weeks of the 8 weeks of during the implementation. So the goal is, for future recommendations, implementing patient wristband barcode scanning. I do hope that I can spread this and actually look at getting this published, because it really did show an improvement on barcode scanning in ambulatory. And again, there is a nice shift with continuing to focus on inpatient, what we do in the inpatient setting, but also now looking at what we do in ambulatory and ensuring quality and safety of our members. We want to educate our members, our patients, about active verification. It's so important. It goes hand in hand with barcode scanning to make sure that they are the right patient receiving the right medication. And it's being out there, team surveys, looking at them and asking them what they need to help ensure safe practices, because there are clinical staff, there are frontline teams. So it's really important to engage them, bring them together and have committees, robust committees to focus on what is working well and what's not working well. What are our gaps? What are our challenges? What should we keep or what should we tweak? So it's really important to have them engaged, because they want to do well. They're in healthcare to do well and support our members, our patients. So it's really important to get their input as well. And of course, there's a cost analysis component to this, a cost savings component to this, because we want to make sure that there are no adverse events, because then it impacts them going to an urgent care should there be an adverse event because of a wrong medication being administered or a wrong dose being administered, or even administered to the wrong patient. So we want to look at the overall picture, because as I continued, or I would like to have continued with this project, is to look at an association with medication administration errors in ambulatory, and if there was a visit to urgent care or to the ED, what does that look like? Because our EDs are impacted. So where would that cost analysis, what would that look like from that perspective, if this is something that you want to implement? So for any project, looking at any type of a cost savings to the organization is really important as well. So in summary, medication safety in ambulatory care requires a national and global focus. Again, this is our first stop for many of our patients. They come to ambulatory care to receive care. About 10%, between 10 and 15% of our patients actually require inpatient hospital care. So 85% of the population receives their primary care through the ambulatory care setting. Using systematic approaches, innovation and technology combined with human factors, self-reflection, taking that step back is so important, and taking that pause. It's really important before we administer any type of medications to our members. And then, of course, looking at technology, looking at what would we be able to do as far as technology. And I was very fortunate with this clinic that the system was already in place. They have a radiology department, and they already print bands for radiology for patients receiving any type of x-rays, etc. So I was able to use that and work with my radiology team to see if I could borrow their system for the 8 weeks, and if we can print patient identification bands for our patients as they could check in to see their primary care physician. So I was very fortunate. It was a great effort by the entire team. It was a collaboration, utilizing a collaborative approach, bringing everybody together and really sharing what we were trying to do in ambulatory. This project overall does highlight the benefits of using wristbands and barcode scanning during medication administration in ambulatory care. We all know it's being done in inpatient, but it's really important to focus on ambulatory care and using these technologies to help with applying the principles of Gene Watson, the Caritas principles, and ensuring safe care is applied, and quality and safe care is applied to our members. I think I'm done. I know I spoke a little bit too fast, and I may have left a couple of things out, but are there any questions from the group?
Hi, Nancy. This is Ty Canish. I just wanted to say I don't have any questions, but what a fascinating project. It's not something I would even think about, and having worked as a nurse practitioner in ambulatory care for many, many years, it really does hold merit. So thank you for doing this.
You're very welcome. It was really eye-opening for me to go from inpatient for, gosh, almost 32 years working as inpatient nurse in maternal child, to go to education in ambulatory and rounding. And I'm like, wow, what perfect timing this is, because now I'm working on my DNP and my project, and what can I do to help support quality and safety in ambulatory? And, you are seeing a nice shift with the focusing on ambulatory quality and safety. So I'm hoping to see more literature out there, more evidence-based approaches with regards to patient identification and medication administration. So more to come. I'm sure we're going to see a lot more work being done. Thank you for that.
This is Dr. Bruno and Dr. Sanchez. I really appreciated your presentation. I thought it was creative, really clever of you to identify existing practical resources that could be tapped in the ambulatory setting um, to decrease medication errors. It's just so important. I hope that you publish this study so that you can reach many more practitioners, and best of luck for the future.
Thank you. You guys are really encouraging me to do it, because I know I've been saying that I wanted to do this, but I think now it's really reinvigorated me to do this and continue to work on this, because it's so important. And being in ambulatory now for the past 3.5 years, there's a need, and we need to, bring awareness. We need to focus on ambulatory as well. And working in the inpatient side with all of our regulatory agencies and stuff, and we always have to be survey ready, and we want to do the right thing. But, I think we can do a little bit too in ambulatory, and our patients want that. They do. And our staff want it too. They want to do the right thing. So I'm excited. I actually am going to start working on getting this published. Thank you.
So I had a question for you. You had mentioned that the clinic already had an established scanning system. Did you do a
Mhm.
cost analysis of what it would be for an organization to want to take on this as an initiative if they did not already have it established in their MAR?
Yeah, no, I didn't get that far yet. I was fortunate because the clinic that I chose, the department that I chose already had it established in their department, in that clinic, in that primary care setting. So I was very fortunate with that. But that is something that I was hoping to do and spread throughout the service area, which would have required me to do more of the financial piece to that, the analysis to see how much it would cost to bring in the system, printer system, having them wired and hardwired into Health Connect, because we use Epic Health Connect, having that wired and programmed into Health Connect in the other departments that don't have it. So it would have been a little bit more definitely financial analysis. And that was hoping that it was something that I can do, but then I transitioned into a new role out of the service area. So I'm hoping this is something that I can continue to work on and bring it to the new service area. So I may have more information on that as I continue with this project.
Yeah, and just another thought to go with that, considering that as a community, we're all trying to transition to something where we're more environmentally friendly.
Mhm.
Naturally, using bandages, arm bandages can over time increase your, I guess, your carbon footprint. So that
Mhm.
would be something else interesting to think of is what could the impact be to improve the safety, but also perhaps decrease the use of some of the materials.
Absolutely, absolutely. One thing that we are fortunate to have, and I know that many organizations, healthcare plans may have this as well, is that our members do have access to their own medical record. And it's, a small little piece of the whole gamut of their medical records, but their patient identification number is a QR code already, and it's similar to the QR code that we have on our patient identification bands. And all they have to do is pull it up on their phone. So that might be another way to capture, the right patient, pulling it up on the phone. But again, it goes with, will it be easy for our older members to use and log in? So that's a little bit of something that I want to look at as well, because we do have that ability to pull up our medical record on our phone through the app and then swipe it to see our QR code. And it does work, because we did try it on one, but that wasn't my project. So we did try it on one and it did scan it. So that's something that I'm looking at even bringing to the table as well, to use that more as well, so that we don't have to print.
Sure. And thinking about those patients that may have technology barriers, perhaps as they're checking in
Exactly.
with registration, printing something, and then they just have on
Exactly.
them like a piece of paper versus a plastic armband, which,
Absolutely.
yeah,
Yes,
great thoughts.
absolutely. Yeah. Thank you.
I have a question, Dr. Sanchez. With such a significant decrease in medication errors, why do you think that this isn't already in place across various settings?
There wasn't literature to support it. It's not common practice in ambulatory care to place armbands during medication administration in the back office. We do use bands for radiology. In my service area, we use bands for radiology, or in my organization. We may occasionally band for laboratory, but it's not something that is traditional or something that's every day that we do in ambulatory care. And during my research, there wasn't a lot of literature to support that process. And so I think we have opportunity to look at that a little bit deeper, to see what we can do to support and improve medication administration errors in the back office, because it's all about, the access, getting our patients in, getting them out. And then with the amount of medications that we're administering, especially during vaccinations, during our pediatric patients, they're getting 7 or 8 vaccinations, and we want to make sure that they're getting the right vaccinations. So I think we have a little bit more work to do to help support, but there's, some literature to support evidence-based practice of using barcode scanning, but it's not something that is routine in ambulatory care.
Mhm. Yeah, this was really wonderful. Thank you.
You're welcome.
Do we have any further questions for Dr. Sanchez? All right, wonderful work. We appreciate what you've presented today, and thank you everyone for attending. Please be sure to join our future presentations this week, and thank you again, Dr. Sanchez, for your work today.
Thank you for having me. Have a great day, everybody.
Thank you.